Now, I think criticism of the service model is absolutely accurate, and I pull my hair out about the issue of, you know, if you're going to do a split fill, and we've explored this, and I think split fill gets at least partially to the waste issue, it really needs to be just in time. I mean, it has to be just in time, and it needs to be tied to an enhanced care model. There has to be an intervention. Do I think that should be in the physician's office? Yes. Are physicians, you know, running to me say, I want to offer you another service for which I'm not going to be reimbursed? No. Right. So we've looked at building it internally, right? And everybody who's doing split fills doing exactly the same thing, and a lot of payers are doing it, right? So, and adherence. So let's not go down that path because that is way too complicated. So there's a fascinating study looking at TKIs and CML. And everybody in the study had good insurance. They didn't have a lot of out-of-pocket. And what the study showed was that if you increase the patient responsibility, noncompliance went up from, I don't know, 12% to 17%. Okay, so there is some cost sensitivity and compliance, but that's not the conclusion I draw. Why the heck are 12% of people not taking a drug that could cure you? What the heck is going through their heads? Which tells me that, and that's not a drug that has a lot of side effects. It has some side effects. So here's the question. Let's not pretend that we're going to improve compliance by this. It's got nothing to do with that. Compliance is a whole different issue, right? And what the delivery model and care model to promote compliance should be, that's a whole separate discussion. Right. So people get really emotional about this thing.
And can I just add one thing? Because we're talking about a lot of structural issues, we're talking about reimbursement, and what we haven't touched upon is really in terms of focus with the patient. So there's a problem here that we have, as we know, that in certain states, and more states are trying to pass parity laws, meaning that that it will not disadvantage a patient to basically get an oral drug. That's a good thing. There's actually a national parity bill that has come up that's important. But you know, some of these patients and some of these tiers, and by the way, when we start now talking about the ACA and we look at, you know, 80 to 85% of the plans are bronze and silver.
Closed
so
formularies.
They're very attractive. Well, not only closed formularies, with absolutely
But not for cancer drugs.
But,
listen,
but here's the problem.
Drugs.
Here's the problem. The problem is the coinsurance, the part the patient has to pay. So as we talk about, even on the private side, some of the tiering plans and things like that, patients are disadvantaged a lot of times economically in terms of getting the oral drug. And that's something that we basically have to overcome. That's a problem.
Yeah, and this whole discussion we're having really ties back into some ways and something we haven't talked about at all, which is the irrational buy and bill system that we have up there, where oncologists are the only medical specialists who are really compensated largely from running a pharmacy business rather than for their cognitive and technical skills and the cognitive and technical services they do. So I think ultimately one of the things that it won't be the solution to this problem, but you're talking about with community oncologists replacing their income. They're paid for being a physician. It's kind of much of their compensation comes from their ability to run a pharmacy business for their classic chemotherapy drugs. And no, we don't do that for any other specialists, rather an irrational system that's come up. So maybe one of the things, if we can actually get to payment reform and pay oncologists appropriately for their cognitive and technical services and not make them depend on drug profits. Even if they are the pharmacy, they can run those things through at cost or near cost and actually be compensated like other medical specialists in our system based on, again, on their cognitive.
Ted, I want to make sure you're seated because I'm going to come to